So I would say the first trimester, Dr. Abu Hamid's talk was really excellent. So how many of you have started applying the AIUM first trimester detailed to your studies? Oh, that's great. So especially when it comes to evaluating the heart, I mean, now with all these recommendations and these guidelines, it's starting to help improve our detection of early congenital heart disease. So very similar to, as Dr. Hamid did, his title was Fetal Heart, so basically clues to diagnosis. So I don't have a specific case to focus on, but I have multiple cases. And of course, this is coming from more of an MFM perspective. And a lot of these cases, I would have to say, since I do a lot of QA at my own site, I retrospectively review these, and I'll be like, oh, this is real time, this is real life, this is, how are you able to identify this? And so many of these don't have a fetal echo. So this is during the level of MFM. Okay, so case one at 26 weeks, patient, came in for a late anatomy scan, and as you're looking at this heart, you can see that clearly more likely a normal four-chamber will access. You start to question, but sometimes when you're scanning, it could be just your angle of insonation, how certain views, how the right side of the heart could look big, but that's when you start utilizing all your different planes. When you look at the four-chamber, you want to look at a transverse view. You want to look at a different angle just to confirm what you see. And what do you guys see here? So you notice at 26 weeks, there's a little bit of a right-left disproportion. So definitely ventricular disproportion. So I just wanted you guys to keep that in your mind, ventricular disproportion in the four-chamber. And of course, taking all the recommended views, taking a look at the outflows, you start moving into the 3-vessel trachea view. And as previously discussed, we know that the PA should be greater, if not equal, than the aorta greater than the SVC. And what do you see here in this 3-vessel trachea view? And I wish I had a polling like Dr. Coppell, but I did not apply that. So you notice looking at this 3-vessel trachea view, you see how the aortic arch, the transverse aortic arch looks very small and skinny. So of course, this is when you start to think, what is actually going on in your head? So your next step, of course, you're going to turn on color Doppler. And that kind of solidifies and also makes you think, confirm that this, something's truly wrong in this area. So just also another helpful tip, because I always get a lot of questions like, well, how do you know if the pulmonary artery is large, really, in comparison to the aorta just being, regular size? Well, if you compare the aorta to the SVC, the aorta should never be similar in size to the SVC. So in this case, as you're looking at this clip in grayscale, they are almost similar in size. So of course, there's some suspicion too that the aorta is small. And when you're looking at the aortic arch, I know some of you probably don't include the aortic arch as part of the routine view, but if you do, you also want to be careful when you're looking at this area, especially in grayscale, that you don't want to have the 2-for-1 special, meaning to say that you'll have it where the ductus arteriosus tends to overlap the aortic arch. So one of my tips that I always try to teach my sonographers is you always have to identify those head and neck vessels. Completely separate them to the point of also identifying the ductus arteriosus. And looking at this clip, what do you guys see? And here, I'll just go ahead and get, and there's actually the grayscale image. And it's very easy if you don't, train your eye to really focus on what you're looking at. This is something that could be overlooked completely. So notice that the transverse aortic arch is very skinny. I would say almost hypoplastic in comparison, to the caliber. So, and of course with color Doppler. And color Doppler, typically I would say, pretty much confirms what you're seeing, but grayscale is key. So don't be quick to actually turn on color right away, but take a few minutes to really evaluate those structures in grayscale. So this is now where you're going to start having your thinking caps on. So you have ventricular disproportion in the 4-chamber. You also notice that the aorta in a 3-vessel trachea view is small, specifically the transverse arch. And you notice that the aortic arch is also narrow and has a skinny aortic arch. So what could possibly be the most likely diagnosis? Or what would you suspect? And I see the fellows are like smiling here. Yep, coarctation of the aorta. So again, I see thumbs up. So again, just little clues to really, help you identify what could be the possible diagnosis. And it's hard, sometimes as imagers, sonographers, especially coming from MFM, we can't exactly pinpoint what it could be, but being able to identify in which you could be like, let's take this patient to the next level of care, having them do a dedicated fetal echo with a specialist or to peds cardiology. All right, so next case. Here is a Dr. Abu Hamid gave a wonderful first trimester talk. And at our lab, we now take a look at the 4-chamber as well as the 3-vessel trachea view in color Doppler. So looking at the 4-chamber, first thing you want to assess is look at cardiac access, because that is the most obvious that you would want to identify, especially in the first trimester. But now going onto the 3-vessel trachea area, and the sonographer actually put 3-vessel view area because they were not sure. So I would say that if you're not sure, even that inkling feeling, because we know what is normal. Now, when it comes to the point when you start to doubt, like something is up, then I would say, again, have a second set of eyes, have the physician come in and really take a closer look. So what do you notice with this 3-vessel or this level of the 3-vessel trachea view? And I can tell the sonographer who did scan was newly trained, so she was getting a little bit more familiar with the 3-vessel trachea view, so she wasn't even sure if that was proper. So long story short, what happened was they, ultimately the physician did suboptimal the 3-vessel trachea. The patient ended up, for whatever reason, ended up leaving and getting another anatomy scan elsewhere. Somewhat of an, non-compliant patient, and then ended up coming back to us at 30 weeks because there was a referral from the outside saying that we think the heart looks abnormal. So we see that a lot in MFM, as most of you know. So looking at the 4-chamber, again, easy to say, cardiac access looks normal. We see a normal right and left side of the heart, proportionate as well. You can also see the pulmonary veins coming in. The valves are opening and closing, both in systole and diastole. So it looks like a perfectly normal 4-chamber. However, we had another sonographer scanning this, and she's like, Michelle, I'm having a hard time getting the right ventricular outflow tract. And typically what we do is for our lab, we include crossing as part of our standard views for the sweep. And here you could kind of see where the pulmonary artery is at, and that's by, again, identifying the branch pulmonary arteries. I always tend to follow that, especially when it comes to abnormalities or if you're unsure, especially in terms of complicated or complex abnormalities. And of course, this is the area of the 5-chamber view. So this is more of an oblique view, just demonstrating these vessels. And of course, just showing with color Doppler. Does anyone have a hint? Yes, transposition of the great arteries. So you could here see the parallel vessels, and also just looking at this clip, you could almost identify those branch pulmonary arteries entering into the left ventricle. So my experience, I felt, was what was helpful for me is I always follow the branch PAs, because those are my favorite structures too when it comes to the heart. So you could actually see that nicely. And of course, here's looking at the 3-vessel trachea view. For transposition of the great arteries, you'll see a single great vessel, of course, of normal size. And this is typically the aorta, how the aorta is anterior located. And you don't see the main pulmonary artery because it's posteriorly located, and it's not seen in this view. So again, just take a look at the level of the 3-vessel trachea view. And you'll see this rightward convex shape of the aorta that is pretty typical that you see with transposition. So I think all of you have said it. So in the first trimester, always, if you see even a single great vessel in the 3VT, that's also one of the clues to be like, this patient probably we can bring back in 15 weeks to take a look. Sometimes when you're trying to get the right ventricular outflow tract, you'll notice it's very difficult obtaining that, and it's because it's just the vessels are parallel. They're not crossing. And also you'll notice lack of crossing. And also you'll see an abnormal four-chamber view and recognize those parallel vessels. And one single great vessel of normal size, which is seen in a three-vessel trachea view. So of course, and this is transposition of the great arteries. Okay, case number 3. Is this normal or abnormal? Or actually, raise your hands if you guys think this is normal. What about abnormal? Okay. So looking at this is very easy as you're going through the clip to say like, wow, this could possibly be a partial AVSD. Because you actually start to see an area as it's panning through. You'll see the linear insertion of the valves. You also see what looks like to be possibly an absent septum primum. And as you go up to the three-vessel trachea view, what do you guys see here? There's an absent bridging vein. And you also see that extra vessel, which is actually to the left of the pulmonary artery. So again, that's just a four-chamber view, demonstrating a cross-sectional view of the left SVC at the border of the left atrium. So it's dilated, of course, and it's entering to the right atrium. So that's what we're actually seeing when you're actually scanning through the four-chamber, and it's very easy to suspect. Like, I think this is a partial AVSD. So that is the pitfall. Just want you everyone to be aware is of the anatomic course of the coronary sinus, especially when it's dilated. And here, as your level of the AV valves, you could see what looks like to be that circular structure. That is the coronary sinus. So again, clues, as you saw, dilated coronary sinus in a four-chamber view, extra vessel, which is left to the pulmonary artery, and absent bridge vein. This, of course, is a persistent left SVC. And this is my last case here. Is this normal or abnormal? Raise your hand if it's normal. Abnormal? All right, so one of the things I always try to teach my trainees too is when looking at the four-chamber heart, anything that you notice is suspicious in a four-chamber heart, just turn 90 degrees. So take a look at also on the long axis. And this is what I see. So this is actually a normal anatomic structure. And so this is also known as the eustachian valve. So the foraminal valley flaps from right to left, but sometimes, especially further along in gestational age, and plus with our high resolution imaging, we're able to see a lot of things that we could not see 15 years ago. And with that being said, if you have the eustachian valve, which is slightly prominent, this can actually be seen at the level of the four-chamber. So what exactly is the eustachian valve? This is located at the level of the opening of the IVC, and this is what directs the highly oxygenated blood originating from the ductus venosus to the foraminal valley, and can also be mistaken for the flap of the foraminal valley, which it shouldn't because the flap is from right to left. And that's pretty much it. Good job, guys.